Welcome to this topic. This is a combined topic of fibromyalgia and sarcoidosis. So we're going to start with fibromyalgia. What is the definition of fibromyalgia? Well, this is a chronic disorder, usually characterized by widespread musculoskeletal pain, also by fatigue, tenderness, sleep pattern changes, anxiety, depression, and sometimes changes in bowel functions. This is also sometimes called fibrositis. And this started as a cluster of symptoms for many years. So it was a cluster syndrome. And then in 1991, the World Health Organization defined it as a disease. This is sometimes characterized as a soft tissue rheumatism. So what are the causes of fibromyalgia? Well, the causes or etiology is actually still unclear. There seems to be some link to endocrine transmitters such as serotonin, such as possibly growth hormone, cortisol, or even substance P. There seems to be some dysregulation of the autonomic and endocrine system, so they're not working together very well. Fibromyalgia is not life-threatening, it's not deforming, and it's not usually a progressive disease. It does seem to come and go. You can have good days and bad days, and some of the most hallmark symptoms or associations are definite pressure point tenderness, anxiety, and depression. Here's a map. So let's look at our map. Well, it's not very clear cut in trying to find some demographics or epidemiology geographically, but what we do know is that 80 to 90% of fibromyalgia patients are women, and first-degree relatives are 8 times more likely to have these symptoms. And mostly this is occurring between the ages of 30 and 60. So this is kind of a syndrome or a disease of middle-aged and primarily women. Risk factors. There's no single cause, but there may be some associated risk factors, and those include some traumatic events, such as childbirth, such as a witnessed trauma, surgery, which can be seen as a trauma. Also, repetitive strain injury, like a repetitive joint injury even. Viral infection, possibly a link to chemical exposure, and there does seem to possibly be some genetic predisposition. Extreme or chronic stress may be a risk factor, but there is no really good evidence-based science to connect those things yet. So as a nurse, you are trying to intercept symptoms. You're also trying to assess for symptoms, and what are you going to look for? You will be hearing about widespread pain, and there are 18 distinct points that we follow on the body. So this widespread, in order to categorize it as widespread pain, it has to occur on both sides of the body, so left and right, and then also above and below the waist. So you're kind of looking for that diffuse pain, not just one area. Another characteristic is fatigue. Many patients have daytime fatigue and also sleep disorders, nighttime insomnia leading to, again, repeated daytime fatigue. So definitely that tiredness component. Cognitive difficulties. Often you'll hear from patients something called a fibrofog, inability to concentrate, inability to follow through on tasks, lack of ability to pay attention. Anxiety also a factor here. And then depression. Many people who have fibromyalgia also experience a pretty high level of depression. Also headaches and possibly GI symptoms such as pain or cramping. So fibromyalgia may coexist with some other symptoms, which does also make it hard to define. Things like chronic fatigue syndrome, irritable bowel syndrome, other anxiety disorders, even other somatoform disorders, kind of a body dysmorphic syndrome perhaps. Many people, again, with fibromyalgia, they have trouble with fatigue to the point where they don't sleep well, but they also wake up frequently when they are sleeping, and there seems to be possibly even a sleep apnea component there. This slide is illustrating some of those tender points, showing you again above the waist and below the waist, and then left and right on each side of the body. So looking for 18 distinct points, and not that your patient would have to have all 18, but they should have that kind of widespread diffuse pain. So nursing assessment, looking for those signs of discomfort, doing the good what's up for pain, the assessment of 18 pressure points. Sometimes patients are self-reporting these on like a a piece of paper, like a screening tool, and they're actually like drawing on where they're having pain. Depression screening, anxiety screening, asking good questions, perhaps in person or via a tool, a written tool perhaps. How often do you feel this way? How long have you felt this way? Those kind of things. Outside of that HPI and a little bit of physical assessment, there are no lab tests to confirm fibromyalgia, but this is almost a disease of exclusion. So you're going to look at other things first, make sure those aren't causing issues before you would really settle on fibromyalgia as a provider. Things we would rule out would be anemia, thyroid disorders, other systemic disorders such as lupus. We might look at a ESR, eosinophilic sedimentation rate, or perhaps a CRP to look for any chronic inflammation. So treatment of fibromyalgia. Well, we're going to treat this probably, to be honest, symptomatically. For muscle pain, we're going to think about some pain medications, trying to use over-the-counter pain medications such as Tylenol before we would really go into the big gun narcotics. Muscle pain, we would think about maybe muscle relaxants. Depression and anxiety, definitely treating that with many of the medications you know. If we thought there was an inflammatory component, possibly Motrin or naproxen, those kind of over-the-counter anti-inflammatories. Other treatments to consider: lifestyle, getting these folks up and moving, getting them to work through, some of this pain, I suppose. Stress management, stretching, relaxation. There are some other newer therapies on the market for this disorder, and that may include something like biofeedback, cognitive behavioral therapy, which may work well with the depression and anxiety, possibly even massage, acupuncture, maybe even chiropractic treatment techniques. So nursing interventions for fibromyalgia, we want good assessment of symptoms, good documentation of symptoms as well, supportive care for symptoms, medication if necessary, planning care to avoid bad days and try and target care for good days, recognizing that as a pattern, trying to assist with sleep hygiene, giving tips and tricks for better sleep, and working with the patient to kind of develop a plan of care that they can adhere to. Things like fibro fog, not being able to follow through on tasks. We really need to have patients self-drive this their own care plan. So what are goals and outcomes for fibromyalgia? Well, we would like patients to be productive and able to complete ADLs. We would like patients to be free from pain. We would like patients to be involved with their care and be able to decide on a treatment plan that works for them. We may wind up using the interprofessional team, such as physical therapy, diet, etc. And keeping on top of good assessment for these patients, including especially that mood and affect, to really probably tailor a plan more to them than a lot of other diseases. This is going to be pretty individualized, and we want to make sure that we're helping make a difference for these folks. Some resources are listed at the bottom of this slide, and this concludes the portion of fibromyalgia on our lecture. The next topic we'll talk about briefly is sarcoidosis. So what is sarcoidosis? Well, this is not a cluster of symptoms. This is a really distinctly different disorder. It's a granulomatous disorder, really, that has also an unknown cause. Oftentimes this shows up in the lungs, so it's tend to be thought of a disease of the lungs, but it's not necessarily just that. So what they have found is that granulomas are occurring in the lymph nodes. And granulomas themselves, this kind of cluster of bad cells, they can contain lymphocytes, macrophages, epithelioid cells, and giant cells. These cells are clumping together, probably where they shouldn't, and forming a granuloma. So sarcoidosis is an autoimmune disorder. We didn't see that with fibromyalgia, but we are going to call sarcoidosis an autoimmune disorder. They have found a link with T lymphocytes and that they increase with sarcoidosis. Because these granulomas are often found in the lungs, the alveolar cells in the lungs are the ones that are getting damaged. You can imagine if you're damaging the alveolar cells in the alveoli in the lungs, we're going to have lung problems. Chronic inflammation in the lung area can cause fibrosis. Fibrosis, so scar tissue in the lungs. And if there's scar tissue in the lungs, becomes less elastic, less able to exchange gas. So that leads to a lot of our complications. Cor pulmonale, which is right-sided heart failure, this is actually the heart can't push against the stiffened part of the lung. It becomes less elastic, and you could actually see some heart involvement here as well. So sarcoidosis, some demographics and epidemiology. Who does this happen to? Well, it does affect mostly young to middle adults, mostly between 20 and 50. Most affected are African American, especially African American women, and people of Northern European origin. So think Scandinavian, Norwegian, those folks. There may be a link with tuberculosis. It's possibly contagious via the vector of tuberculosis. Some other viruses as well may transmit sarcoidosis, and they think that maybe this kind of mutation of cells may be linked with organ transplantation. There may be a genetic link overall, and there may also be an environmental risk with dust and mold. So many times the symptoms of sarcoidosis go unnoticed, and it's frequently found when looking for something else. Many people have no symptoms, or you may see some of that lung involvement, such as cough, shortness of breath, maybe even weight loss, night sweats, or fatigue, as we've heard with some of our other chronic autoimmune disorders. Sarcoidosis most commonly affects your lungs, but it can actually occur in any other organ in your body, and a common organ that we've seen sarcoidosis involvement is the eyes. So doing a good vision assessment, noticing visual changes, that would be hallmark to start thinking about sarcoidosis as well. In addition to the lungs and the eyes, you can see skin changes, and this would appear as a rash or raised bumps on the body. This slide is showing some pictures of sarcoidosis. We see some of the patchy white infiltrate areas on the x-rays. So those are some sarcoidosis fibrotic areas. And then for the skin on the right-hand side of the slide, we're seeing raised bumps, patchy areas, also some isolated bumps, or even maybe those granulomas right under the skin. Two pictures of the back of the neck here, but it can occur in any area on the body. So nursing assessment, lung assessment, skin assessment, knowing that this may arise or occur in the lymph nodes, we'll do some lymph node assessment, especially with advanced practice nurses, and a good HPI of symptoms, trying to discern any difficulty breathing, cough, etc. Vision changes, as I mentioned. Labs to check. Again, this is also often found when looking for something else. So another diagnosis almost of exclusion. We're going to rule out other things first. Probably do a chest x-ray, may do some lung function tests, possibly a lung biopsy if we're trying to look at the specific tissue to see if it's fibrotic or not. Possible mediastinoscopy or a bronchoscopy, going deeper into the lungs to look at tissue. And possible CT scan, which would give you a clearer picture of lymph nodes throughout the body. So treatment of sarcoidosis, we will consider some medications, but also some other treatments. Not everyone who has sarcoidosis needs treatment. Up to 30% of patients with sarcoidosis will have their symptoms improve with no treatment. So you may not need any treatment, but if you had a severe form of sarcoidosis, we may consider corticosteroids such as prednisone. We may consider rheumatoid arthritis type meds such as methotrexate. Again, trying to knock that immune response, that autoimmune response in particular. And in very few severe cases, if it really is affecting the lungs, both very few cases and very severe cases, if it's truly causing lung compromise, these patients may require a lung transplant. Severe heart involvement may involve a heart transplant as well. So nursing interventions for sarcoidosis, good assessment, good HPI of symptoms. If we are going to prescribe medications, then it's good medication teaching, including steroid management, probably long-term daily management of medications. This is a chronic disease, so if these symptoms prolong over 2 years, then it's termed chronic sarcoidosis. There's also a depression and anxiety component with this chronic disease, recognizing that and possibly treating it as well. Recognition of worsening symptoms, especially worsening lung involvement or eye involvement. Goals and outcomes for sarcoidosis. Usually good outcomes if the symptoms and the disease itself are mild. More challenging when it becomes more chronic, or especially if you would have multi-organ involvement. Having steroids as part of a treatment plan, it's often difficult to get rid of the steroids and achieve, still that same effect. It is difficult to diagnose, so we're going to look at other diseases first. Remember that 2/3 of this disease will resolve on its own without any treatment. And as a nurse, you especially want to monitor for other organ involvement, especially if the patient has known sarcoidosis and then they start to notice vision changes. Do notify the provider right away. So this concludes our lectures on fibromyalgia and sarcoidosis. For the purposes of our topics, I would like you to kind of be able to differentiate between the two, know what the differences are, but these are really standalone topics, but with both distinct characteristics.